Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having back on the podcast as the January lead article, my dear friend and colleague, Professor Marie Plante from Quebec, Canada. And we're going to be speaking about this very important article titled Minimally Invasive Compared to Open Surgery in Patients with Low-Risk Cervical Cancer Following Simple Hysterectomy, an exploratory analysis from the SHAPE trial. Marie, welcome, and once again, congratulations, of course, for this very important landmark study. You and the team, I'm sure, are exceedingly proud and happy that it's finally been concluded and it's been reported, and that is changing practice for our patients. So again, welcome and congratulations.
Well, thank you, Pedro.
So Marie, I wanted to just start by asking if you can just kind of give a brief overview of the actual SHAPE trial, what the results are, before we get into some of the discussion on this particular study.
Right. So the SHAPE trial is a prospective international randomized trial looking at patients with what we call low risk criteria. And just to remind people what the low risks are, we're talking about an HPV histology like the squamous, adenocarcinoma adenosquamous, lesions under 2 centimeters, but in addition, lesions with limited depth of a stromal invasion, under 50% on MRI, and less than 10 millimeter depth of invasion on the pathology. So we randomized 700 patients to receive either a simple HIS or rad-HIS with lymph node evaluation. And essentially, the results indicated that simple hysterectomy was in fact not inferior to radical hysterectomy with respect to the pelvic recurrence rate at 3 years. In addition, the trial showed less morbidity, particularly urological complications such as urinary incontinence and urinary retention with the simple hysterectomy. And the trial also showed better quality of life and sexual health with simple hysterectomy. And in fact, we've published a separate article, very extensive, very elaborate on those issues of quality of life and sexual health. And it was published in JCO, in fact, October 2024. Sarah Ferguson is the lead author. And lastly, what has just come out is we also conducted a health economics evaluation and concluded that simple hysterectomy is, in fact, less costly and more effective in terms of quality compared to rad-HIS. And again, that was just published in November in JGO by Janice Kwan, the first author. So that's in a nutshell what the SHAPE trial has demonstrated.
Excellent. Fantastic. Thank you for that overview. And I think, we all find it, and I'm sure you do as well, as we start talking about the results of the SHAPE trial in our different forums of discussions and conferences, that a question comes up as it pertains to the surgical approach. So I wanted to just have you talk a little bit about why this SHAPE trial was not an ideal trial to provide a definitive answer on the question of best surgical approach for the simple hysterectomy.
Right, that's correct. Well, unfortunately, when we designed the trial, that's back in 2010, surgical approach was not an issue back then. I mean, no one was talking about it, and it wasn't an issue. It's only with the publication of the famous LAC trial in November 2018 that demonstrated that surgical approach, namely MIS, showed statistically worse outcome with MIS, and that's created a tsunami in the gynecology community, as you know. But at the time of the LAC publication, which was in November 2018, we were in fact 1 year away from completing SHAPE. We completed accrual in November 2019. So it was just 1 year of overlap, if you want. But nevertheless, in that last year of SHAPE, we noted 30% reduction in the MIS following the LAC publication. So all this to say that surgical approach actually was not included as a randomization factor in SHAPE, which means that surgeons could actually decide or choose whichever surgical approach they wanted to do or they deemed preferable for their patients.
Great. So, and Marie, now getting into this particular study, and again, obviously, from the discussion you just had, What were the objectives of this study, and why do you consider this was an important question to be addressed?
Well, as I just said, SHAPE showed that simple HIST was not inferior to rad HIST, but SHAPE did not answer the question as to whether MIS was safe or not. And SHAPE was not designed to answer that question. So since the publication of the LAC trial, there's been numerous retrospective studies and meta-analysis and what you want, looking at safety of MIS, and results of those series are controversial. Some said MIS was worse, and some said MIS was no different. Those studies are retrospective and biases. It's usually studies of radical HIST, not simple HIST, very few for lesions under 2 centimeters and so on. So really the jury was out as to whether MIS is okay for small lesions and if it's okay with simple HIST. So there's also very, very few series that address the safety of MIS for simple hysterectomy with lesions under 2 centimeters. So we decided to go back to the SHAPE database, and we extracted specifically the group of patients who in SHAPE underwent simple HIST, and then we compared outcome between MIS and open surgery to try and answer the question.
Great. So through the course of the podcast, I'm going to be asking some questions from our fellows in the journal. This one comes from Mina Dages in Turkey, and she's asking, were specific criteria or metrics used in the trial to standardize and evaluate the extent of the procedure across different surgeons, both for simple and radical hysterectomy?
Yeah, well, you know, quality of assurance is always a big issue in surgical trials, and it's really a challenge. In SHAPE, we had in the protocol an extensive surgical manual that detailed the requirements for what is a simple HIST and what was a rad HIST. And we required a photograph of the surgical specimen. And I personally reviewed all the pathology reports, the OR dictations, and all the photographs of all the cases. And that's as far as we were able to go in terms of the quality assurance of the procedures that were performed.
Yeah. So tell us about the results of this particular study. What are some of the points that you want to highlight for our audience?
Okay. So from the SHAPE database, we have identified 338 simple hysterectomy. 281, that's 83% of the simple hysterectomy were performed by MIS. 57 patients, or only 17%, had their simple hysterectomy by open surgery. So obviously, this difference, 83% versus 17%, that reflects the fact that surgical approach was not randomized and that surgeons visibly preferred MIS approach, right? Now, with a median of 4.5 years of follow-up, we identified 12 recurrences in the MIS group, and we underwent, and that's 4.3%, and identified 3 recurrences in the open surgery group. So the numbers look different, but in fact, in terms of proportion, is about the same. That's 4.3% versus 5.3%. So we saw no statistical difference in terms of clinical outcomes examined, and that included the pelvic recurrence-free survival, extrapelvic recurrence-free survival, recurrence-free survival, and OS. So those were the clinical outcomes that we studied between those two groups, and we saw no difference. Now, that being said, one should understand and realize that this is an exploratory analysis of the SHAPE trial that was not designed to assess a study surgical approach. The surgical approach, again, was not randomized. There were very few open cases. I repeat, it was only 57, and there were very few recurrences, 15 in total. So this is why we remain very cautious in our conclusion, and we believe that our data needs to be validated in a prospective, much larger cohort of patients. This is more of a hypothesis generating sort of a publication, if you want.
Excellent.
I would say, Pedro, yeah?
Yeah, go ahead.
Yeah. I would say that there are 2 findings that worry me in this, in our data, if you want. Number 1, 6 of the 7 extrapelvic recurrences occurred in the MIS group. There was only one extrapelvic recurrence in the open group. And those two extrapelvic recurrences were carcinomatosis, right? That suggests that MIS perhaps played a role there. And you have published in the updated lag trial and others that this is one of the concerns with MIS, if there is visible lesions on the cervix, is to maybe promote carcinomatosis. So that's one worry that I have about our data. And the second is all the 4 cervical cancer deaths occurred in the MIS group, and they were none in the open group. And among those 4 deaths, there were the 2 carcinomatosis. So although I'm telling you that the clinical outcomes examine OS and extrapelvic and recurrences and all that is not statistically significant, it's still concerning. And that's the message that I would like to get people to come across with. I don't know if that makes sense to you.
Yeah, no, and I think I'm very glad that you outlined that so well, articulated it so well, because I think that oftentimes some of this information is somewhat misinterpreted, but you have clearly outlined exactly how to interpret this information. So I'm very glad to hear you say that. This next question is from Roberta Masobrio in Italy. And she asked, fewer patients treated with laparoscopy had residual disease in the hysterectomy specimen. Do you think this could have influenced the study outcomes?
Yes, I think it probably did. Just to remind the people listening, is this 43% of patients in the MIS group had residual disease in the hysterectomy specimen, and 58% of patients in the open surgery group had residual disease. So again, I think this is a reflection of the fact that surgical approach was not randomized. And my hypothesis is that perhaps surgeons chose the open approach in patients with macroscopic or visible lesions, for instance, and patients who had a cervical biopsy for diagnosis, and so maybe surgeons then in those cases favored open surgery. So it's hard to tell the impact of that one variable alone, but I think it speaks to the main limitation of the study, which again is the low number of open cases and the low number of recurrences. So there's so much you can do when you try to do a statistical analysis and to see meaningful differences between the 2 groups. But yeah, that's what I've been thinking about as an explanation.
Excellent. So this question, of course, we knew was going to come up. It's actually from several fellows, so I'm not going to name them all, but they ask, what protective maneuvers would you include in a trial to compare laparoscopic versus open in patients who meet the shape criteria for simple hysterectomy? And then do you know how many cases were performed with the use of a manipulator in the shape trial?
Indeed, I do get that question a lot, and unfortunately, we do not have that data. The information on uterine manipulator and protective maneuvers and all those sorts of things. Again, back in 2010s, no one even was thinking about that. So we did not collect that in the source document. So we're not able to go back and find that. The risk of recurrence with the manipulator wasn't known at that time. So, but if I was to reduce shape, I would definitely require that the cervix be closed and forbid the use of uterine manipulator. Yeah,
that's a major if.
Yeah.
That's a major if.
Yeah.
So Marie, this question is from Raikan Bolatvikova, and she's asking, adjuvant treatment was done in MIS group more often than in the open group, 10% versus 3%. While not significantly different in survival rates in both groups, can we go as far as suggesting that perhaps if there were any predicted poorer outcomes for MIS, that these were mitigated by adding the additional adjuvant therapy?
I think it's a very good question. I would just want to make a correction, is that adjuvant treatment was given in 10% of MIS and 5.3% in open. It's maybe just a typo error, but so again, surgical approach was not randomized. So we see some differences, for instance, in the rate of positive lymph nodes between the 2 groups. For instance, there were 4% positive nodes in the MIS and none in the open group. So again, this is and explanations as to why more MIS patients received adjuvant treatments. But I think it does make sense that radiation therapy compensated and probably contributed to reduce the local recurrences in patients who had high-risk features, such as the positive margins, positive nodes, and we have some patients with lesions over 2 centimeters, and all of those that I just mentioned were more frequent in the simple hysterectomy group. So I think that probably indeed the fact that they receive radiation therapy reduced the rate of recurrences and in fact might raise a bias. But it all goes back to the fact that it wasn't randomized, the surgical approach. So that's the problem. Yeah.
So I'm going to jump to a question by Roberto Masobrio, which brings up another frequently asked questions, as you know. Do you believe that limiting the analyses to patients who underwent a conization prior to minimally invasive surgery may have altered the study results? And of course, obviously, as we know, this question that keeps coming up of patients who have a conization, can they undergo minimally invasive surgery? What are your thoughts?
Yeah. Well, I think I do believe that it impacted or the results. In fact, as you probably know, we are also conducted another exploratory analysis of the SHAPE trial, and that we look specifically at the relationship between the pre-hysterectomy leap cone margins, the type of hysterectomy, whether it was simple or radical, and the pattern of recurrences. And what we found is among 174 patients in SHAPE with negative leap cone margins, we identified 2 recurrences in the pelvis. So that's a rate of 1.4%. One of those recurrences occurred after a simple HIS and one after the rad HIS, and both happened to occur in the MIS. We had no extrapelvic recurrences, no death in any of the groups if patients had negative leap cone margins prior to the hysterectomy. So to me, this would suggest that patients with negative leap cone margins are very low-risk patients in terms of recurrences. And perhaps MIS might be a reasonable, safe approach in those particular cases. So this data that I just quoted has been submitted for publication by my colleague, Dr. Sven Manner. We haven't heard yet, but it's on its way.
Yeah, and it's interesting you mentioned that even with negative margins, there were still recurrences in the simple hysterectomy specimen. Very, very interesting. So
yeah, and I think that speaks to the fact, and the same was noted as well in CONSERVE. The same speaks to the fact that they, in both of their groups in CONSERVE, they had patients with negative cone margins. And one had residual disease higher up in the canal, the famous skip lesions, right? So one has to, I think, always keep in mind that even if the margins are negative, it doesn't give you a 100% guarantee that there's nothing else. And that is why, if one does MIS, but I'd still always think there might be something close to cervix. Don't put in a manipulator. And I think that this way it's even safer. But I think, Pedro, the way in the future that I've been thinking about this a lot lately is that perhaps doing a prehysterectomy leap cone with negative margins might be the way to go in the future. Why? Because if the entire lesion is removed with that leap cone with negative margins, then the pathologist can give you exactly the size of the lesion, exactly the depth of stromal invasion, tell you about LVSI, such that you can precisely determine, accurately determine if the patient meets the SHAPE low risk criteria. And if they do, then you can have a simple HIS. But if patient does not meet the SHAPE criteria because it's deeper invasion, whatever, then that patient should have a rad HIS. In addition, it helps you decide the choice of surgical approach. The margin's negative, you have all the low risk criteria and everything. Well, perhaps then you may decide to do MIS. So I think, and it's very personal what I'm saying here, is that perhaps a pre-HIS leap cone with negative margins might be a triage procedure, you see, to more accurately decide the type of hysterectomy and the surgical approach. I think this is where we're heading.
Yeah, very interesting point, and I had not actually heard that perspective. Another point for further discussion, and certainly another tool that I'll have when I answer that question in the subsequent presentations. Um, Wanted to ask you because this is an interesting question from Jose Villuches from Spain, and he says, given the issues with minimally invasive approach, laparoscopy or robotics, do you think we should be heading back to revisiting the vaginal hysterectomy approach, and particularly again in the simple hysterectomy setting, making it even less complex of a procedure?
Well, I call it the revenge of vaginal surgery. I think it makes perfect sense to do the entire hysterectomy vaginally, because then you close the cervix and you essentially eliminate or minimize the risk of peritoneal carcinomatosis and or contamination. And I think that this has been well demonstrated by Christard Kocher from Germany. And but the problem, Pedro, is that lots of gynae oncologists have just lost the skills and the knowledge about and are not comfortable with doing vaginal surgery, and that's why the skills have shifted to laparoscopy and robotics. But I think there's ways to either apply the protective maneuvers and close cervix, or do a sort of a combo, that is to begin the hysterectomy and the nodes or what have you by laparoscopy and sort of finish it off vaginally. That would also be an option. Yeah.
I think our mutual friend and colleague, the late Michel Roy, would have been very happy to hear you say those words.
Yeah, I think so, yeah.
Um, so then now, Ali Strubhart from Salt Lake City here in the US, she's asking, in thinking of a future clinical trial, are there any findings in this study that you would use to plan to stratify randomization, stage, histology? How would you incorporate this into future study?
Yeah, well, of course. Well, in SHAPE, we actually stratified the data according to histology, to grade and stage. But in future trials, I think it probably would be a good thing to include LVSI as well, which was left. This was open to patients, but it wasn't a randomization factor. Margin status on the prehysterectomy LEAP cone, I think, would be a very important stratification factor as well. Stratifying for residual disease in the hysterectomy specimen is also interesting, but this is an information that you get after the fact, right? This is you get on final pathology, and not at the beginning when you select patients for the procedure. But yes, those are the things I would probably incorporate in the future trials.
Excellent. This one comes from Elena Rodriguez Gonzalez, and she says, based on the current evidence and observed results, what surgical approach do you consider most appropriate in a patient with cervical cancer who meets the SHAPE criteria for simple hysterectomy in your practice today?
Right. Well, personally, again, this is personally, I think that patients who really meet the low-risk SHAPE criteria and who had a prehysterectomy LEAP cone with negative margins, I personally think that a simple hyst is safe and MIS is safe. As I said before, I would nevertheless close the cervix. I wouldn't use a manipulator, always keeping in mind that the negative margins is not 100% guaranteed. There's nothing left higher up in the canal. So I would always sort of play it on the safe side of being very careful. This is what I do.
Yeah. And Marie, just as a follow-up to that, you routinely get an MRI on every patient that you're considering this approach, correct?
I do. And it's probably one of the disadvantages of doing a LEAP cone, just because the MRI is often quite difficult to interpret, because the cervix has got inflammation, it's distorted. The radiologist often will say, well, I see something, but I don't know if it's cancer or just inflammation or whatever. So this is a bit of a difficulty there, yeah.
Yeah, and for you, and this is a recent question that came up in a discussion, are you getting MRIs and PET or just an MRI?
Just an MRI. I think in very low risk of disease, the probability of finding something else is so it becomes quite an extensive or expensive workup. But I don't routinely no.
Excellent. So, Maria, as a last question, are you aware of any future studies, or should we be performing a future study to exactly address this question of the surgical approach for a simple hysterectomy in this very low-risk population?
Well, I think yes. I think doing a randomized trial would be quite an undertaking because we know already the difference in outcome would be very minimal. So you would need a huge number of patients. But as you know, there's the LASH trial, which I think would help answer some of the questions regarding surgical approach. For people who are not familiar, it's a prospective single-arm study, which was developed by the Gemelli group piloted in Italy by Dr. Niccolò Bizzarri and Denis Kerleux. And it's a trial that plans to recruit 974 patients. So that's almost 1,000 patients with stage 1A, 1A to 1B1, meeting the shape criteria in terms of histology, depth of invasion, and so on, exactly the shape criteria, with the conization and negative margins. And there's even an option of reconing like in Conserve, and also with negative and normal imaging and negative nodes. So those are very ultra low risk patients, and they are planned to undergo MIS for sentinel mapping and simple hysterectomy, obviously with no manipulator. And the primary endpoint is the 3-year disease-free survival. So this trial, I think, will probably consolidate the results that we just saw in the shape subanalysis, but I think with 1,000 patients, it'll provide us with more solid data. In addition, there's the ROC trial, which in the US many people are familiar with, which randomized open to robot rat hist. And as you probably know, the protocol was amended since the publication of SHAPE to allow patients meeting SHAPE criteria to receive a simple hist. So obviously, we don't know how many patients in the ROC trial ultimately will have a simple hist, but it will provide additional prospective data and also will allow a sort of a mini comparison between the simple hist and rat hist patients in that group of patients just to see if there's a difference. So that'll provide us with more data prospectively. So yeah.
Very exciting, very, very exciting. And I want to again thank you so much for the invitation. Thank you for joining us in the podcast. Thank you for submitting this paper to our journal. Always very, very excited to speak with you and learn about all of the findings from this really landmark study. Congratulations once again. Thank you for what you continue to contribute to the field of gynecologic oncology. Always, always a pleasure. I'm honored.
If I could just make a closing comments, Pedro. So we thought we had all figured it out with SHAPE, but I'm afraid that things are just coming a lot more complicated, right? Because before we didn't used to bother, we just did a rat hist, but now selecting patients for less radical surgery has become much more complicated and requires expert understanding and pathology and imaging. And yeah, it's made things a little bit more complicated.
Yes, no, I mean, thank you. Thank you for obviously opening up so many additional questions. But yeah, exciting to see what's to come in the next few years.
Great. Well, it's been a pleasure as well, Pedro. Thank you for the invitation.
Take care, Marie. Thank you.
All right.